In the name of Father, of the Son, and the Holy Spirit, one God. Amen. Dear students, my beloveds, my friends, young colleagues, take your pens, papers. Today we will go and today we will talk about lung carcinoma, lung cancer. So take your pens, papers for making the notes and clarify the questions that were misunderstood by you, confused you during these previous board exams. And let's go. So cigarette smoking is implicated in approximately 95% of all lung cancer cases. My beloveds, remember that in your future medical practice. Actually, we can say that no smoking, no lung cancer. Yes, we can tell that we can not just lung cancer. Actually, a lot of medical health conditions, health issues. And remember that. So if you have, doesn't matter what specialty you're in. So you talk to patient. You are a gynecologist. You are an infectious disease specialist. I don't know, even public health. Especially public health. So you understand, you get that the patient is a smoker. So you have to explain him not to smoke or quit smoking. I don't talk about the patients, I don't talk about doctors or public health so-called specialists that are smokers. It's something absolutely shameful, completely. So the risk increases with the number of cigarettes smoking per day and the duration of smoking, obviously. So I repeat, cigarette smoking is implicated in approximately 95% of all lung cancer cases. So what's clinical importance of that, my beloveds, and the exam relevance? So this is the most critical risk factor that ever exists. So always ask about history of smoking, age of initiations, cessation attempts, and exposure to second-hand smoke. And once again, doesn't matter what specialty you're in, and doesn't matter what pathological condition per person get in. So emphasize smoking cessation as the single most effective preventive measure. I repeat it several times, and I will repeat, and we'll talk about it till I live. So, by the God's sake. So be prepared to discuss cessation strategies. Well, actually, we talk about, you will ask about that. We'll be asked about nicotine replacement therapy, NRT. Bupropion, very clean. Actually, the people are divided in two groups: smokers, those smokers just quit smoking, period. So exam question focus: risk factor identification, public health implications, primary prevention strategies. Okay, good. Now about lung cancer in never smokers. While smoking is the primary cause, an estimated, so from 5 up to even 20% of lung cancers, and the high proportion actually in women, particularly adenocarcinoma, occur in individuals who never smoked. So when WHO said that never smoked, what is this? Defined as a smoking less than 100 cigarettes in their lifetime. There's 5 packets. What's clinical importance of that? And examiner relevance as well. So differential diagnosis. Lung cancer should not be dismissed completely in never smoker presenting with persistent respiratory symptoms. We think about lung cancer always when a patient is a smoker. Okay, that's absolutely right. But lung cancer should not be dismissed in never smokers presenting, my beloveds, with persistent respiratory symptoms. Okay? Etiology exploration. So in never smokers, consider other risk factors. So they talked about radon exposure, second leading cause. I answer like that. But occupational exposures, of course, it's asbestos, arsenic, chromium, nickel, but asbestos is the top. What else? Air pollution, genetic predisposition, and certain lung diseases, for example, pulmonary fibrosis. No, COPD. When you said COPD, it doesn't matter. Let it be chronic obstructive pulmonary disease. So a molecular profile, something interesting. Actually, I don't know. You will be asked about that on your big board exams, but we know that never smokers with lung cancer, especially adenocarcinoma, are more likely to harbor targetable mutations like EGFR mutations or anaplastic lymphoma kinase rearrangements. But anyway, just keep it in your mind. So exam question focus: risk factors beyond smoking, specific mutations in never smokers, in an importance of molecular testing. Who knows? Yeah. Great divide. So lung cancer is broadly divided into two main histological types, worlds apart. So-called small cell lung cancer, NSCLC, just small cell, we will talk. Small cell, we will understand the small cell is a small cancer, accounting for about 10 up to 15%, and less non-small lung cancer, NSCLC, SCLC and non-SCLC, making up the rest, 85-90%. These behave very differently. What's clinical importance of that? An exam relevance. So small cell carcinoma, small cell cancer, characterized by rapid growth, early metastasis, and strong association with smoking. Other presents with paraneoplastic syndromes, typically chemosensitive initially, but relapse is common. Surgery is rarely an option due to an early spread. A broader, actually this is a small carcinoma, small lung cancer, non-small lung cancer. A broader category including adenocarcinoma, squamous cell carcinoma, and large cell carcinoma generally grows slower than small cell, and treatment options vary widely based on stage and molecular characteristics, often including surgery for early stages. Diagnostic imperative. Pathological confirmation and distinction between small cell and non-small cell is the first crucial step after suspicion, as it dictates entirely different management pathways. But honestly, lung cancer is something very, very, very bad, with very poor prognosis. Small cell, non-small cell. No, you don't answer in this manner, but just remember, if we fix a diagnosis, prognosis is very, very, very bad. God forbid. Huh? So that's why no smoking. Just that. Period. That's it. Yeah. Exam question for Qs. So distinguishing features: histology, growth rate, metastatic potential, treatment approach of small cell versus non-small cell. Now about the trio, non-small lung cancer trio: adenocarcinoma, squamous cell, and large cell carcinoma, myeloids. Okay, let's go. Adenocarcinoma, the most common type of lung cancer overall, especially in women and never smokers, typically arise peripherally, on the periphery. Squamous cell carcinoma, strongly linked to smoking, usually arises centrally near major bronchi, leading to symptoms like cough, hemoptysis, or bronchial obstruction. Can cause hypercalcemia due to parathyroid hormone-related protein production. Large cell carcinoma, a diagnosis of exclusion, less common, can occur in any part of the lung and tends to grow and spread quickly. Clinical importance, actually an exam relevance, yeah. Symptoms correlation: central tumors, often squamous, are more likely to cause cough, hemoptysis, wheezing, or post-obstructive pneumonia. Peripheral tumors, often adenocarcinoma, may be asymptomatic until large or metastatic or cause pleuritic chest pain. Biopsy interpretation. Understanding these subtypes is vital for interpreting pathology reports and guiding further molecular testing, EGFR, ALK, etc. Paraneoplastic associations. Squamous cell carcinoma with hypercalcemia. Let it be. Exam question focus. Typical locations. Patient demographics, men, women. Common symptoms and paraneoplastic associations of non-small lung cancer. Subtypes, of course. Next, lung cancer often presents with vague, non-specific symptoms. Persistent cough, dyspnea, chest pain, fatigue, weight loss, or can be asymptomatic until an advanced stage. This contributes to late diagnosis in many cases. So, clinical importance in exam relevance. Relevance. What happens to me? Relevance, of course. High index suspicion. Maintain a high index of suspicion, especially in high-risk individuals. A new or changing cough in a smoker is a red flag, especially with weight loss. Investigate persistently. Symptoms like persistent cough, that is more than 3 weeks, unexplained hemoptysis, no, if it's not a tuberculosis, of course, unexplained weight loss, I repeat it, or finger clubbing warrant prompt investigation, typically starting with a chest X-ray, followed by computer tomography if suspicion remains. Metastatic symptoms. So be aware of symptoms from common metastatic sites. What are they? Brain. We will see headaches, maybe. Seizures, focal neurological deficits. Bone, pain, pathological fractures, spinal cord compression. Liver, jaundice, abdominal pain, abnormal liver functional tests. Adrenals, often asymptomatic, actually rare, but can cause adrenal insufficiency in bilateral and extensive. Exam question for Qs. Common presenting symptoms, red flag symptoms, approach to a patient with suspected lung cancer, common signs of metastasis and their clinical manifestations. Then, lung cancer, particularly small cell, is notorious for causing a wide array of paraneoplastic syndromes. Clinical syndromes involving non-metastatic systemic effects that accompany malignancy. What's clinical importance and exam relevance? Diagnostic clues. Sometimes a paraneoplastic syndrome is the first manifestation of a lung cancer. Now, common examples. Small cell. Syndrome of inappropriate antidiuretic hormone secretion. Hyponatremia. Cushing, sometimes pronouncing Cushing syndrome. No, Cushing syndrome. Ectopic adrenocorticotropic hormone, ACTH, production. Hyperglycemia, hypokalemia, hypertension. Lambert-Eaton myasthenic syndrome. Lambert-Eaton myasthenic syndrome. Proximal muscle weakness, autonomic dysfunction, improves with exercise. Don't confuse with autoimmune disorders. Actually, good question. Squamous cell carcinoma, hypercalcemia due to parathyroid hormone-related protein. All types, no less specific, of course. Hypertrophic osteoarthropathy, clubbing and periostosis of long bones. Hypertrophic osteoarthropathy, that is clubbing. and periostitis of long bones, dermatomyositis. Management. Treating the underlying cancer often resolves the paraneoplastic syndrome. Treat lung cancer. You are welcome. God bless. Specific syndromes treatment may also be needed. What else? Exam question focusing. Linking specific paraneoplastic syndromes for lung cancer types, especially small cell and squamous, recognizing clinical features and initial management steps. Next, staging. So famous TNM system. Fascinating, and you have to remember that. Fascinating fact. The tumor node metastasis. Tumor node metastasis. It's an acronym of TNM, abbreviation. That means staging system established by American Joint Committee of Cancer. Is a globally recognized now language for describing the anatomical extent of lung cancer. Yes, it's complex, but crucial for determining prognosis and treatment. Clinical importance and exam relevance. So T letter, tumor, describes the size and local extent of the primary tumor. For example, invasion into nearby structures. N, that is nodes, N letter, it's nodes. So indicates the presence and location of regional lymph node involvement. M, metastasis, denotes the presence or absence of distant metastasis. Okay, so guiding treatment. Early stage, for example, stage 1, 2, some 3A for non-small. Often amenable to curative intense surgery, possibly with adjuvant, post-operative chemotherapy or radiotherapy. So about this adjuvant therapy, chemotherapy, radiotherapy. Anyway, so locally advanced, for example, stage 3B or 3C for non-small cancer, often treated with concurrent chemoradiotherapy, sometimes followed by consolidative immunotherapy, very fashionable now, highly controversial. What else? Metastatic, stage 4 for non-small, or extensive stage for small. Primarily managed with systemic therapy, chemotherapy, targeted therapy, immunotherapy, palliative radiotherapy for symptomatic sites. You answer in this manner. Limited stage small cell, treated with chemoradiotherapy with curative intent. So prognostic value, higher stage generally correlates with poorer prognosis. Exam question focus, understanding the basic principles of TNM staging, how staged, you will be asked about that definitely, absolutely. So understanding the basic principles of TNM staging, how stage dictates broad treatment strategies, for example, surgery for early non-small, systemic therapy for, so-called systemic therapy for metastatic disease. So largely sufficient. Yeah, I clarified all questions. Thanks for your attention. Don't forget to follow and subscribe my Dr. Y YouTube channel, my beloveds, as well as my private channel in Telegram, also Dr. Y. Now I'm Dr. Armen actually, but internet name is Dr. Y. So Dr. WHY, like question, without question mark, of course. So Dr. WHY, you tap in searching mode in Telegram, it's a bot. You click start and you choose your plan. Stay blessed.